use of botulinum toxin. I can hardly hear myself. There's somebody very loud. Can you turn this off, maybe? So this lecture is about the use of botulinum toxin in connection with immediate functional loading. It's an important topic for us because we are doing a unique work and we have unique possibilities to work with botulinum toxin and to either prophylactically work against problems which can happen, or if there's mobility of the prosthetic construction to fix this. So what is the justification, the background for this treatment? After surgery and injury, bone undergoes more remodeling. Due to remodeling, the bone decreases in mineralization. I mean, this is always like this. So if you have surgery or fracture, there is always going to be less mineralization after some time, let's say after 6 weeks. So the bone's resistance against the forces which are transported into the bone by the implant actually will decrease. Implants will then become mobile and prosthetic constructions are then also mobile. It depends, of course, if all implants are affected or only a few. Experience shows that administering of botulinum toxin can reverse this process, and both implant-borne constructions can become, both the implant and the constructions can become stable. The bone in the interface to the implant will have to cope with less forces and can build up mineralization. We found out about this in the old time when we worked with the BOI implants. We worked even, of course, with less bone. And there was more remodeling, of course, because of the T-shaped slot, which was made for the BOI implant. And at that time, approximately almost 20 years ago, I started to work with botulinum toxin, and I used it on many cases when there was some problem. At that time, however, the prosthetic rules which we use today were not so clear. We were using more the rules of regular dentistry. Also, we created intercuspidations and so on. We don't do this anymore. So in any case, the chance that instability will happen is much lower today than with the treatments which we did 20 years ago. But nevertheless, it can become necessary to do something against mobility of implants. So we can assume that this treatment works only in the technology of the strategic implant, because if rough surfaced implants or two-stage implants become mobile, the interface will be colonialized quickly and the granulation tissue which develops will be a barrier for new osseointegration. Furthermore, the low transmission areas, as per the design of the strategic implant, are typically positioned in sterile compartments of the body, which means even, I mean, we know that we don't have periimplantitis, we don't have all these peri-implant infections, but even if we had them, we wouldn't have the problems, we wouldn't lose the implant so quickly, because the low transmission areas, these threads, are in sterile compartments. This is a big difference to the crestal implants, because crestal implants always kind of integrate in the first cortical and a little bit below. And as soon as the infection is there, then very quickly the whole implant is affected. So there's no way back. And if this is infected, of course, there's nothing that holds. And these two-stage implants, they don't have these apical threads typically. Now, looking at the literature, what is sometimes confusing people is this word botulinum toxin. It sounds really crazy, dangerous. So what are we doing with this? I want to remind you that Mr. Paracelsus, Dr. Paracelsus, many years ago, centuries ago, made it clear. He said that all things are poison and there's nothing that is harmless. So even if you drink water too much, it can be very harmful. Even if you work with botulinum toxin, it will be no problem if you follow the rules and if the dosage is appropriate. A lot about botulinum toxin from our group, from the doctors who are not now in the IF. So in my textbook, Principles of BOI, there are some chapters about the use of botulinum toxin. This is already more than 15 years ago. Then there were 2 articles in the French language in the journal Implant T. They are available online, and there was a clinical note published in the ID journal, CMF Implant Directions, and Professor Konstantinovic and me published already in 2007. A quite nice overview article